now we'll start with the general pharmacology. We'll try to do all the questions at the end since these are smaller chapters. Okay. So, starting with the pharmacokinetics and dynamics. We've already done this in the discussion. If you remember, pharmacokinetics and dynamics. Kinetics are movement of the drug like absorption, distribution, metabolism and excretion. Now, what about the dynamics? Drug is binding to the receptor, receptor is causing the effect. That is what we have studied in the introduction, if you remember. So, I told you we are going to just build up on the concepts of these. So, starting with the pharmacokinetics, what is the first thing we have studied? This is absorption. I've already told you absorption. If the absorption has to happen, the drug should be lipid soluble or water soluble. It should be lipid soluble. This is what I told you. Yes, the lipid soluble drugs are absorbed. They can cross the membrane. Now, which drugs are lipid soluble? Which drugs are lipid soluble? Try to understand. If you remember in the ANS chapter, I told you tertiary amines and quaternary amines. I told you quaternary amines, water mixes in water, so it is water soluble. Tertiary amines are lipid soluble. This is what I told you. Now, how do you write tertiary amines? Let us suppose one example is NH3. What about quaternary amines? NH4 plus. You can see here plus. This is an ionized form. So, ionized forms are water soluble and non-ionized forms are lipid soluble. Non-ionized forms are lipid soluble. So, the drug has to be non-ionized form to be lipid soluble. This is what is important for absorption. This is one factor. Okay. Now, we will see the factors that are affecting the absorption. Before that, we will try to see most of the drugs are absorbed by simple diffusion. That is what we have seen in the beginning as well. But what is absorption? It is the movement of drug from the site of administration into the systemic circulation. That also I told you. Now, let us suppose I am giving a drug and this drug is acidic drug. Let us suppose I am giving an acidic drug. This has come, it is going into the stomach, then it will go into the small intestine. So, we will see an acid drug when it goes into the stomach. The acid is, the medium of stomach is acid. So, acid and acid, there will be no reaction. So, it will be in non-ionized form. I told you non-ionized form is lipid soluble. So, lipid soluble drug can cross the membrane and be absorbed. So, it will cross membrane. This is what I want you to understand. So, if the drug has to cross the membrane, it has to be in unionized or non-ionized form. Now, the same acidic drug now will come into the small intestine. What is the medium of small intestine? It is basic. Now, acid and base will combine together, it will form ionized form, so it will become water soluble. Now, it will not cross the membrane. It will not cross the membrane. If I give a basic drug, the basic drug will first go into the stomach, so it is acid. Medium of stomach is acid, isn't it? So, basic drug and acidic medium, when they combine together, it will again cause ionized form. So, this is water soluble and it will not cross the membrane. If this basic drug goes into the intestine, it is alkaline medium. So, this is basic medium and it will become non-ionized. It will become lipid soluble, it will cross membrane, that's all. So, what is important for absorption? It is the non-ionized form. When the drug is in non-ionized form, it will cross the membrane. So, this is when absorption happens, when these are in non-ionized form. Now, the MCQs, let us see. Acidic drugs are maximally unionized in. Acidic drugs are maximally unionized in which medium? Acid medium or basic medium? It should not react. No, it is an acid medium. So, it should be in a stomach. Okay. So, if the acidic drugs are maximally unionized in stomach, acidic drugs are maximally absorbed in which part? Stomach or small intestine? Stomach or small intestine? What is it? Answer. Sir, obviously it is maximally unionized in stomach, so it should be absorbed from the stomach. No. The answer is duodenum. This is what I told you in the beginning of the class. I told you most of the drugs are absorbed from the duodenum. Doesn't matter. The solubility, the acidity, doesn't matter. It will always be absorbed from duodenum. Why? Because yes, absorption is dependent on the form, the solubility, lipid and water solubility, but absorption is mainly dependent on the surface area. Most important factor is surface area. Since the surface area of duodenum is more, most of the drugs are absorbed in duodenum. Doesn't matter whether it is an acidic drug or basic drug. This is what I want you to understand. That is why I told you so much of this. Now, if you understood this, what are the factors that is decreasing the absorption? Let us suppose a person is having diarrhea. Will the drug stay in the stomach and the intestine for a longer period of time? No, it will stay for a shorter period of time. So, diarrhea will decrease the absorption. If a person is having shorter bowel, let us suppose he has been operated and some part of the bowel has been taken out. Now, what will happen here? The absorption will be decreased because the surface area is decreased. These are the factors that is decreasing the absorption. Good. Now, how do you know this ionization? I told you that if the drug is in non-ionized form, it will be absorbed. Now, how can you know if the drug is in ionized form or non-ionized form? If it is in ionized form, how much of it is in ionized and how much of it is in non-ionized? That is why we have an equation that is known as Henderson-Hasselbalch equation. Now, I don't want you to remember the equation, but I want you to remember something that is known as pKa. pKa comes from this Henderson-Hasselbalch equation. What does this pKa says? pKa is the pH at which 50% of drug is in ionized form, okay, and 50% of the drug is in non-ionized form. So 50% is ionized and other 50% is non-ionized. It is what is pKa. This is what has been asked in the exam so many times. Now, if you want to go one step further and if you want to remember, if pH minus pKa is equal to 1, one form will become 90%, other form will become 10%. Now, if it becomes 2, the other form will become, one form will become 99 and other form will become 1%. Why? Because this is logarithm. This is logarithm. When you see that equation, you will understand. Okay. So, this is the calculations, but I just wanted to remember what is pKa. If you understood this much, next we will talk about a concept that is known as bioavailability. What do you mean by bioavailability? See, bioavailability means the amount of drug that is coming into the systemic circulation unchanged. It is the amount of drug that is reaching the systemic circulation unchanged is what is bioavailability. What do I mean by this? So, let us see what is this bioavailability. If I am giving a 10 milligram drug orally, it goes into the mouth, then again pharynx, esophagus, stomach, duodenum. I told you most of the drug is absorbed from duodenum, then stomach. Let us suppose from duodenum and stomach the drug is being absorbed. Now, how much is absorbed? Let me tell you. Let us suppose 8 milligram of this drug is absorbed and 2 milligram is lost. Okay. Now, this 8 milligram, which vein will go into the liver? This is known as portal vein. So, the portal vein will take 8 milligram of drug into the liver. Now, what will liver do? Liver will also take some of the drug with itself. So, let us suppose liver is taking 2 milligram again. 2 milligram again. This is known as first pass metabolism. This is known as first pass metabolism. If you remember, I told you before, there is absorption, distribution, and then there is metabolism. Now, what I am saying is, even before absorption has happened, the drug is passing through the liver for the first time. That is why this is known as first pass metabolism. So, first pass metabolism and metabolism are completely different. So, let us suppose if 2 milligram is taken up by the liver. Now, how much will reach the inferior vena cava from the liver? How much will reach? 6 milligram. So, I gave 10 milligram and 6 milligram has come. What is the bioavailability? This is the bioavailability. Did you understand? So, if you understood this much, what could be the factors that are affecting the bioavailability? If there is more absorption, if more amount of drug is absorbed, bioavailability will be more, obviously. Yes, so that is why bioavailability is directly proportional to absorption. Now, if more drug is utilized, in the liver, let us suppose the liver is taking 5 mg from 8 milligram, how much will go? 3 milligram. Did you understand? If first pass metabolism is more, bioavailability will be decreased. That is why bioavailability is inversely proportional to the first pass metabolism. If first pass metabolism increases, bioavailability decreases. This is what I want you to remember from the bioavailability. These are the factors that are affecting the bioavailability. Now, coming to the drugs with high first pass metabolism, you have to know this. These are nitrates. No, seriously, nitrates have large first pass metabolism. That is the mnemonic itself. Seriously means salbutamol, nitrates means nitrates, hydrocot means have, nitrates have large lignocaine first pass metabolism, first pass P for propranolol, metabolism for morphine. Seriously is salbutamol, nitrates for nitrates. I just want you to remember nitrates. Nitrates have large first pass metabolism, so some amount of drug is going into the absorption. That is the reason why we give the drug in a sublingual route. When you give it sublingually, you have seen patients taking this tablet under the tongue. No, this will bypass the first pass metabolism. That is why sublingual route is preferred. Now, if you understood this much, next there is a concept that is known as plasma concentration time graph. Really important, has been asked in exam so many times. Let me make it simple for you. Let us suppose this is plasma concentration and this is time. Okay, when you're giving the drug, what will happen to the drug in the plasma? When you give the drug, it will slowly start to increase first. It will reach a peak plasma concentration, and after some time this will be metabolized and excreted. Yes, this is the graph that is there. That's all. So this peak plasma concentration is what is known as Cmax. So Cmax is maximum plasma concentration. Now, how much time does it take to reach this maximum plasma concentration is known as Tmax. That is what is Tmax. It is the time taken to reach Cmax. Did you understand this much? That's all. That is Cmax and Tmax. Now, the area that is present under this entire curve is known as bioavailability. So, area under curve is known as bioavailability. That's what. Now, they'll ask you one more question. Which of these represents the rate of absorption? Rate means speed, no. Which one will tell you if the drug is absorbing faster or slower? Which one? Cmax, Tmax or AUC? If you use common sense, it is Tmax, because it is telling you the time, no? It will tell you the time in which drug is being absorbed. If it is absorbed in 5 minutes, and if the drug is absorbed in 10 minutes, 5 and 10, which one is faster? 5 is faster. That is why Tmax will tell you the rate of absorption. If you cannot remember this much, T and T, rate mein T hai, Tmax mein T hai, so T and T, rate of absorption, Tmax. Please remember this. Bioavailability, AUC. Maximum plasma concentration, Cmax. That's all about this graph. So, once you finish the absorption, next I told you there is distribution. What is distribution? From the systemic circulation, drug is distributed to various organs of the body. That is what I told you. When it goes to the organs that we want, it gives the effect. When it goes to the other organs, that we don't want its effect on, it will cause side effects. So, what did I tell you before? Distribution is the reason why we have effects. Now, what I am telling you is distribution is the reason why we have both effects and side effects as well. So, distribution is really important for us. Now, what are the factors that are affecting this distribution? Again, these are same: fat content, lipid solubility and the tissue binding. Let us suppose if the fat content is more and if the drug is lipid soluble, obviously lipid soluble drugs will stay more in the fat content. Yes. So, both of these are directly proportional. Okay. If the drug is lipid soluble, it will be absorbed more. If there is more fat content, lipid soluble drugs will stay in the fat content. So, that is why volume of distribution is directly proportional to this. Now tissue binding. Tissue binding means drug is going to a tissue and binding inside it. If the drug is staying in the tissue for a longer period of time, that means volume of distribution is more, so it is also directly proportional. Next comes to the plasma protein binding. This is what is important. See, let us suppose this is systemic circulation and it has to go into an organ to cause effect. That is what is distribution I told you. Okay, that is what is distribution I told you. Now, inside the plasma we have proteins. If the drug is bound to this protein, can this drug cross the membrane and go into the tissue? No, proteins cannot cross the membrane. Drug also cannot cross the membrane. So it will stay back. That means if plasma protein binding is increased, distribution is decreased. So this is inversely proportional. Fat content, lipid solubility and the tissue binding are directly proportional. Plasma protein binding is inversely proportional. This is what I want you to understand. Now, coming to the some drugs which have high volume of distribution and high ppb. If there is high volume of distribution, that means the drug is in tissues. Okay. So the drug is in the tissues. If the drug has high plasma protein binding, the drug is in the blood vessels. Okay, good. Now, what would be the problem if the patient has taken a drug with high ABD or high ppb? What could be the problem? Let me tell you. Let us suppose a person is having a drug toxicity. How do you treat it? Most of the times when you don't have antidotes, you will do dialysis. For dialysis to happen, the drug has to be in the blood and then it goes into dialysis machine and it has to be filtered. This is how dialysis works. Now, if the patient has taken a drug with high ABD, the drug is already in the tissues. It is not in the plasma, so it cannot be filtered through dialysis machine. Okay. If the drug has high plasma protein binding, the drug is bound to the plasma protein. Now, can it be filtered into the dialysis machine? No, it will stay along with the protein. So, the drug cannot be filtered. Did you understand this much? That is why you cannot do dialysis in these drugs. So, you avoid dialysis. That is the mnemonic itself. A for A, amphetamines, V, verapamil, O, opioids and OP, I is imipramine, D for digoxin and dialysis for diazepam. These are the drugs where you avoid dialysis. Okay. Now, coming to the metabolism. We have talked about the absorption, distribution, now metabolism. What is the aim of metabolism? If you remember, we are converting lipid soluble drugs into water soluble drugs. Yes. This is how we are doing it. What does it mean by water soluble? I told you water soluble means it has to be in ionized form. So that is what we will do. There are two phases. First phase will break the drug. Second phase, there will be a conjugation reaction. What will this conjugation reaction do? We will add a negatively charged molecule to this pieces of drugs, negatively charged molecules. So, these have become ionized. That means they have become water soluble. That means they will be excreted. That's all. Did you understand? So, this is what we are doing in metabolism. First step, they are breaking the drug into smaller pieces. Now, to these smaller pieces, we are adding a conjugate that is negatively charged. So, it will become water soluble. That is what is happening. Now, conjugation means adding something. What is the most commonly added conjugate group? It is glucuronidyl group. That is why this reaction is known as glucuronidation. Or you can also add methyl group, methylation, sulfation. You can see here methylation, sulfation, acetylation, glutathione, glucuronidation. So, if you are adding anything, those are phase 2 reactions. Easy to remember: glucuronidation, glutathione, sulfation, acetylation, methylation. Now, when you come to the phase 1 I told you it is breakdown. So, you can see here cyclization, hydrolysis, deamination, oxidation. Oxidation means removal of hydrogen. Yes. Reduction means removal of oxygen. So all these things we are breaking something. So oxidation, reduction, cyclization, all of these are phase 1. So this is how you can easily remember. Now what is important? Almost all of the phase 1 reactions and the glucuronidation reaction, all of this is happening with the help of microsomal enzymes. Other things are happening via non-microsomal enzymes. Now, why are these microsomal enzymes important? These are inducible enzymes. Microsomal are inducible. That means you can either increase or decrease these enzymes. So, if you see, almost all of the drugs are metabolized by microsomal enzymes. Why? Phase 1 happens to all the drugs. Yes. Phase 2, you see here glucuronidation. Glucuronidation is the most common reaction. So I am seeing microsomal enzymes are doing this glucuronidation. So almost all the reactions of almost all the drugs are happening via microsomal enzymes. Microsomal enzymes are inducible. Now what do you mean by inducible? Let us suppose, we'll write it somewhere else. Yes, we'll write it here. If we induce enzymes will increase in number. If enzymes are increased, it will cause more metabolism. So, what will happen to the effect? The drug effect will decrease and it will cause drug failure. Now, if we inhibit these enzymes, these are known as enzyme inhibitors. What will happen? Enzymes will decrease. If there are decreased enzymes, will metabolism happen? No, there is decrease in metabolism. So what will happen to the drug concentration? Drug concentration will increase, effect will increase, and if the effect increases too much, it will cause toxicity. So inducers are causing failure, inhibitors are causing toxicity. This is what I want you to understand. Now, which are these microsomal enzymes? These are known as CYP enzymes. You might have studied most common CYP is CYP3A4. So now we will see there are some drugs which will induce these enzymes and inhibit these enzymes. Now there is a list that you need to know, but in the class I told you with the help of a story to remember all of these drugs. Now since the time doesn't permit, I cannot tell you the entire story, but I'll tell you the gist of it. I told you there are a group of people who are traveling, and because of the bad GPS, it has caused irritation. So I have told you that bad GPS means crap GPS induces irritation. This is what I told you in the story, yes, if you remember. So CRAPGPS, C for carbamazepine, R for rifampicin, A for alcohol, P for phenytoin, G for glycofulvin, P for phenobarbital, S for smoking. You need to remember these. Then I told you, whenever there is irritation, the other friend tries to inhibit this irritation or decrease this inhibition by giving Coke, quick Coke. I also told you he will give alcohol, grapefruit juice, vitamin C, all of these, but at least for now remember quick Coke. Quick means quinidine, Coke means clarithromycin, omeprazole, ketoconazole, erythromycin. At least remember this much. Quick Coke will inhibit the irritation. These are enzyme inhibitors I want you to remember. Okay, so clarithromycin, omeprazole, ketoconazole, erythromycin and quinidine. If you understood this much, now these enzymes can be induced or inhibited by these drugs. Because of this, it will cause effects on other drugs. These are known as drug interactions, very important in the exams. There are many, but I will tell you the most commonly asked drug interactions here. In the exam, they always ask about rifampicin. Yes, person is taking ATT and the person is using OCP. What will happen? Yes, rifampicin is an enzyme inducer. So what will happen to the OCP? OCP is also metabolized by CYP. So this will increase the metabolism of OCP and it will cause OCP failure. This is what I want you to understand. Okay. Next is erythromycin. Erythromycin is a enzyme inhibitor. So in the exam generally they ask you about erythromycin and theophylline. So when erythromycin is given, this will inhibit the enzymes that are metabolizing the theophylline and it will cause theophylline toxicity. Same thing with clarithromycin, it is enzyme inhibitor. So when it is given along with statins, it will increase the toxicity of statins and it will cause statin myopathy. These are 3 clinical cases that are usually asked in the exam. Now, we'll talk about the drugs that are undergoing acetylation. I told you most of the drugs in the phase 2, they will undergo glucuronidation, but there are some drugs that are undergoing acetylation. What is so important about these drugs? There is something very important. Let us try to see. There are known as SHIP drugs which will undergo acetylation. What are these SHIP drugs? S for sulfonamides, H for hydralazine, I for isoniazid, P for procanamide, D for dapsone. Now, all these drugs, instead of glucuronidation, they will undergo acetylation. That is good. Okay. Now, acetylation is done by an enzyme known as NAT enzyme. These enzymes are slow in some people, fast in some people. Yes, so we can call them slow acetylators, fast acetylators. How can you remember? See, if you see Western culture, we call it as fast culture now. So you can easily remember fast acetylators are Americans. So these drugs will be acetylated fastly and metabolized. Now, slow. Slow means Indians. 2/3 of Indians are slow acetylators. If the metabolism is slow, what will happen? These drugs will cause drug-induced erythematosus, drug-induced lupus erythematosus. So, SHIP drugs are causing drug-induced erythematosus in slow acetylators. This is what I want you to understand. With this, you completed the metabolism. So we have finished with the metabolism. I want you to remember the inducers and inhibitors in that. Now coming to the excretion. How does excretion happen? All of you know there is first filtration of the substances and there is reabsorption and then there is secretion. These are the processes, but I want you to focus mainly on the reabsorption. I told you most of the filtrate is reabsorbed. We have seen in the renal system 99% of the sodium is reabsorbed. Here 99% of GFR is reabsorbed. Now for absorption to happen, I told you it should be lipid soluble drugs. So lipid soluble drugs are reabsorbed, water soluble drugs are excreted. So let us suppose if there is a drug poisoning, if there is any drug poisoning, if you want to treat this poisoning, you will tell me hemodialysis. Okay, let it be. Before that, if there is any drug poisoning, how can you treat? If you make the drug water soluble, will it be excreted in the urine and the concentration will be decreased? Yes or no? Yes. How can you make the drug water soluble? That is what we are going to see. We have 2 kinds of drugs. Yes, acidic drugs and basic drug. Examples of acidic drugs, these are aspirin, methotrexate, barbiturates. Remember these. If there is any of this drug poisoning, what can you do? Now, these are acidic drugs. When they come into the PCT, how can you make it water soluble? I told you, water soluble means you have to make them ionized. So, this is acid. Now, if you make the urine alkaline, acid plus alkaline will form what? Ions. Ionized forms, water soluble. These drugs will be excreted, so that is the treatment. So you're making the urine alkaline. So this is what is known as forced alkaline diuresis. Now coming to the basic drugs. Basic drugs are anything with name INE. If it is ending with INE, these drugs are basic drugs. One example I have given is amphetamine. Now, if it is a basic drug, how can you make it water soluble? You have to make the urine acidic. So that is what is known as forced acidic diuresis. That's all. Acid plus base, it will form ionized forms and it is water soluble and it will be excreted. So how can you make the urine alkaline? You already know this by giving bicarbonate, that is sodium bicarbonate, because it is alkaline. Now acidic, it is by ammonium chloride. Ammonium chloride. If you cannot remember this, you can see in the ammonium chloride H and Cl is present. So HCl is acidic. So forced acidic diuresis is done by ammonium chloride. This is what I want you to remember. Now, if you understood this much, next is T half. T half is the time taken by the drug to become 50 percentage, in plasma concentration. So how much time it takes for the drug to become 50 percentage is what is known as T half. There is a formula. If you want to remember this, try to understand with the basics. T half is directly proportional to volume of distribution. T half is directly proportional to volume of distribution. Why? If the volume of distribution is more, the drug will stay in the tissues for a long period of time. If it is staying in the tissues for long period of time, it will take longer time for the drug to become half, because it is not being excreted fastly, isn't it? So if VD increases, T half will increase. Yes. Now what about clearance? If clearance increases, what happens to T half? If the drug is excreted rapidly, so it will reach its 50% faster, no? Did you understand? So the time taken by the drug to become 50% will decrease. So if the clearance is more, T half will decrease. So T half is inversely proportional to clearance. That is why we can write T half is equal to VD by CL. There is a constant 0.693. This is what I want you to understand. Then there is formulas of rate of elimination, clearance and plasma concentration. But what is more important here is the loading dose and the maintenance dose. Yes, loading dose and the maintenance dose. What are they dependent on? This will be asked in the exam. Now, loading dose is equal to AVD into plasma concentration. Loading dose means, see, let us suppose you want the drug to stay in the plasma. This is blood vessel. You want certain amount of drug to stay in the plasma. Okay. Now, in the distribution, what will happen? The drug will go into various tissues. So, in the loading dose, if you want the drug to stay in the blood vessels, it has to fill up all the tissues that it can. That is why you can remember it in a simpler way, that loading dose is directly proportional or is directly dependent on volume of distribution. Now, coming to the maintenance dose. Maintenance dose is equal to clearance into plasma concentration. Let us suppose I have given a 100 mg of drug and 50 mg of drug is eliminated. Now, how can I maintain this 100 mg? I have to give back this 50 mg. So, I am giving how much ever is excreted. So, that is why it is dependent on clearance. This is easy to remember. Maintenance dose is dependent on clearance. Loading dose is dependent on volume of distribution. So, you can see here volume of distribution and loading dose. Yes, this is how you can remember them. Maintenance dose is equal to clearance into plasma concentration. Okay, good. Now we will see the kinetics of drug elimination. How the drugs are being eliminated, what are its kinetics. Yes, we have two kinds of kinetics. First order kinetics and zero order kinetics. I mean, we will see here. First order means constant fraction of drug is eliminated. FRF, constant fraction of drug is being eliminated per hour. In zero hour, constant amount. So, what will happen to T half and clearance? Let us suppose if we increase the dose, even if we increase the dose, constant amount will be excreted. That is why T half will remain constant and clearance will also remain constant. How? Let us take an example. Let us suppose there is a 100 mg drug and 50 milligram is excreted or cleared. Yes, how much will remain? 50 milligram in 1 hour. So, this is what is T half. No, exactly half is removed. So, this is what is T half. Now if I increase the dose, let us suppose I made it 200. Now also I am saying 50% will be excreted. Why? Because it is constant fraction of drug. 200 will become 100 in 1 hour. So what happened? What happened to the T half? T half is constant. How much is cleared? That is also constant. Now coming to the zero order kinetics, I am telling you constant amount of drug is eliminated. Let us suppose 100 mg is becoming 50 mg in 1 hour. Now I increase the dose, I made it to 200 milligram. Now what I am saying is constant amount, only 50 milligram can be excreted here, so it will become 150 mg. So in the next 1 hour, another 50 will be excreted and it will become 100 mg. So what happened to the T half? What happened to the T half? T half is increased. So if you increase the dose, T half will increase. Why T half is increased? Because clearance is reduced. This is what I want you to remember for first and zero order kinetics. That's all. If you want to remember one single thing, F for F, constant fraction. Now why is this important? See, almost all of the drugs will follow the first order kinetics. That means kidney is removing the drug really well. Almost all of the drugs follow the first order kinetics in normal therapeutic doses. But if you give the drug in higher dosages, the kidney will get tired and it will not be able to remove as much as possible because enzymes are used up. Okay, did you understand this much? So all the drugs will follow first order kinetics, but when these drugs are given in higher plasma concentrations, they will follow the zero order kinetics. But there are some drugs which will follow zero order kinetics even in normal plasma concentration. This is what is important. Yes, especially therapeutic plasma concentration. So let us suppose even in therapeutic plasma concentration, there are some drugs that are following this zero order. What are those drugs? These are alcohol, theophylline, phenytoin, heparin and warfarin. Really important. Heparin and warfarin. These are the drugs that are following zero order kinetics even in therapeutic doses. Alcohol will follow the first order kinetics anywhere. So this is the true zero order. Any dose alcohol is zero order. Rest all is first order. When you increase the dose, they will become zero order. But there are some drugs which will have zero order even in therapeutic doses. Those are these. That's all. Now, coming to pharmacodynamics, I already told you drug is binding to receptor to cause effect. That is what is pharmacodynamics. Yes. Now, the tendency with which the drug binds to receptor is known as affinity. Tendency with which drug binds to receptor is what is known as affinity. What about efficacy? The effect that is seen after binding to the receptor is known as efficacy. What is potency? The dose that is required to produce certain effect. That's all. So I told you in the beginning itself, if you know the basics, you understand everything. Drug binding to receptor is affinity, receptor causing effect is efficacy, and the dose that is required to produce this effect is potency. That's all in pharmacodynamics. Now, classification of drugs. So drugs are divided into two. What are they? Agonist, antagonist. Agonist, antagonist. This is what we have told in the beginning in the basic terms. Now we'll see it in detail. Now let us suppose this is the effect. +1 is the maximum effect, -1 is the minimum effect, 0 is in between. So if the drug has maximal effect, that means its intrinsic efficacy is +1, that is known as full agonist. If the drug has submaximal effect means it can be anywhere between 0 to 1. That is what is known as partial agonist. Now concentrate very carefully. See, antagonist means its effect is 0, not reduced, its effect is 0. I am repeating it again, effect is 0. That is what is antagonist. That is what is antagonist. Effect is 0. Now coming to inverse agonist, its effect is reduced. That is -1. That's all. Effect is 0, antagonist. Now there are different types of antagonists. What are they? You can see here: physical antagonism, chemical, physiological and pharmacological. What do you mean by physical? The drug physically binds to the target to prevent the effect. Let us suppose you give activated charcoal in poisonings, that is physical. Now, what about chemical? What about chemical? It binds to the drug chemically. That's all. No? You use protamine sulfate. Yes or no? Protamine sulfate for heparin. This is one example. It neutralizes the heparin. Physiological antagonism means opposite effect by acting on different receptor. Let us suppose in allergy, H1 receptor will cause bronchoconstriction. Now, if you see in anaphylactic shock, what is the drug you give? You give adrenaline. This is what we talked. Adrenaline will act on beta 2 to cause bronchodilation. So, this is a physiological antagonism. Now coming to pharmacological antagonism, this is what is important. We have two: competitive and non-competitive. Competitive and non-competitive, this you will study in biochemistry also. We will see it in a simple way. Okay. So let us suppose this is an enzyme. This is an enzyme. Okay. And this is the active site of the enzyme. So substrate will usually bind to this active site and will cause the effect. Now if we give a drug that looks exactly like this substrate, it will compete with this substrate for the active site. That is what is known as competitive antagonism. That means substrate and inhibitor are similar and they bind to the same site Now inhibitor binds at the active site. So there will be what? Inhibition. But if you increase the dose, you can get the normal effect. I mean, if you increase the substrate, it can push the inhibitor away. This is what we have studied. So the dose is given as Km. In the graphs you will see there is Km is dose and effect is Vm. So if you are getting the normal effect by increasing the dose, Vm is constant. That's all. Coming to the non-competitive. Non-competitive means, see, substrate you can see here. Inhibitor has a different structure and shape. It has a different shape. So, can this bind to this active site? No, it binds to the allosteric site. Unfortunately, when it binds to the allosteric site, it will change the shape of active site and the effect is reduced forever. That means Vm is decreased. Did you understand? But Km is constant. Inhibitor binds at allosteric site. This is what they ask you to remember in a way. Yes, they say competition. Competition means when you are running, kilometers will increase, Km increases. This is how simply you can remember. Vm is constant here. In here, it is exactly opposite for the non-competitive. So, non-competitive means it will bind to the receptor irreversibly. That means even if it goes away, the effect is irreversible because it has changed the shape of the active site. Okay, this is about the competitive and non-competitive. And in this they will ask questions about the Michaelis-Menten graph and stuff you will study in biochemistry. Please try to understand in a simple words. Let us suppose if the graph is crossing here, that means you can remember it as two swords that are crossing. That is what you see in competition. No, this is competitive. Now in this graph you see here, if it is not crossing, that is non-competitive. There is no competition between them. This is what I want you to remember. Now coming to the dose response curves. You see here, this is log dose. Log dose. You have quantal DRC and graded DRC. Graded means it is done in a single person and you can actually grade the effect. Let us suppose we will take this as response. This is 5 milligram dose, this is 10 milligram dose, this is 15 milligram dose. Response is 20, 40, 60, 80, 100. Okay. So what I am saying is, if I give a 5 milligram tablet, it has reduced the BP by 40 milligram of 40 millimeter of Hg in one person. Yes, now I have given a drug B. I have given a drug B 10 milligram, it is reducing up to 80. Now I have given a drug C 15 milligram, it is reducing up to 60. Now you tell me, which drug is more effective? Which drug is more effective? Very easy, no? Efficacy. Which drug is more effective? Obviously the drug that is decreasing 80 millimeters, so it is B. Next C. Next A. So efficacy is directly dependent on height. Okay. Next they'll ask about potency. Which drug is more potent? This is where people might get confused. Which drug is more potent, A, B or C? See, potency means the relative dose required to produce a certain effect. Let us take the certain effect as 40. How much dose is required to reduce 40 millimeter mercury of BP? How much is required? You see here, for drug A only 5, for drug B 10, for drug C 15. So which is most potent, most powerful? It is drug A. So A, B and C. So this is dependent on left-sidedness. So whatever is on the left side of the graph, that is most potent. Whatever is on the height, which one is on the top, that is the most efficacious. That's all. Efficacy and potency you can remember like this. Now quantal DRC is done in population. You can see here, this is what is known as 50% of population. So I call this ED50. I call this ED50. ED50 means effective dose. That means the dose that is required to produce effect in 50% of population. So this is effect. To see effect in 50% of population, what is the dose? That is ED50. Now, the dose that is required to see toxicity in 50% of people is TD50. The dose that is required to produce lethality in 50% of population is LD50. So, LD50 is generally not measured in humans. This is only seen in animals. So, from this you can understand the therapeutic range, index and window. How will you know? What is the formula? It is TD50 by ED50. This is the formula in humans. If let us suppose in animals, it is LD50 by ED50, because it is not ethical to kill humans, no. We cannot check lethal dose. Lethality means death. Now, why this is important? See, therapeutic range means the dose should be in such a way that there should be effect, but it should not cause side effects. So this is the safe window. That we want in a drug. This is what we call it as therapeutic index. So if a drug has low therapeutic index, it will cause toxicity. Low therapeutic index drug will cause toxicity. This is what I want you to understand. Let us suppose I am saying therapeutic index of a drug is from 500 milligram to 1000 milligram. So I can give 600 milligram, 700 milligram, 800 milligram, 900 milligram, good. Now if I say the drug therapeutic index is 10 milligram to 12 milligram. Let us suppose a person has taken 10 milligram tablet and he forgot and he has taken one more. So it will become 20 milligram. He will go into toxicity. So low therapeutic index will cause toxicity. These are the drugs which are having low therapeutic index. Now, if you understood this much, finally we are going into the clinical trials. In this we have something known as scheduled drugs. Scheduled drugs means you might have seen when doctor writes you a prescription, you go and buy a drug. When you turn the drug behind, you will see it was written Schedule H. So Schedule H means these are prescription drugs. If it is written H1, these are antibiotics. There are something known as Schedule X. This is only for narcotic and psychotic drugs. So H and X done. Schedule G is given only under medical supervision. So G, H and X, that's all. Now coming to the OTC drugs, these are given over the counter. That means you don't need any kind of prescription. Orphan drugs. Orphan drugs means these are drugs used for very rare conditions. Example is a drug called Digibind, which is an antidote for digoxin. See, digoxin itself is not used commonly nowadays. Its indication has reduced drastically. So digoxin itself is not being used. If this digoxin causes digoxin toxicity, we have to use Digibind. So you see, it is very rare. So this is an orphan drug. Now, scheduled drugs are done. Coming to the pregnancy drug categories. Now, some drugs are safe in pregnancy, some drugs are not safe. Why? Because these will cause teratogenicity. Now, there are some drugs which are causing teratogenicity in humans. These are known as category D and X. Category X, as it is written, it should never be given in pregnancy. Okay. Example is thalidomide. In the olden days, people used thalidomide for morning sickness and it has caused something known as phocomelia. Category D is also causing teratogenicity, but it can be used when benefit is more than the risk. Category A, B and C are safe to be used. That's all. What will the examiner try to do? They will try to confuse you between Schedule X and Category X. Please don't get confused. Category X is for pregnancy categories. Yes, Schedule X is for narcotic drugs. Please try to understand this subtle difference. Schedule X and Category X are not same. Next, coming to the counterfeit drugs. Spurious drug. Spurious drug means fake drug. They will say this drug is paracetamol, but when you check it, there is no paracetamol in it. Misbranded drugs. That means the labeling is wrong. It might be about the expiry date, it might be about the directions of the use. Yes, there is wrong labeling. That is what is misbranded drugs. Adulterated drugs means some unwanted substances mixed in the drug. That's all. Now, finally coming to the drug development. In drug development, there are 4 phases. Phase 1, Phase 2, Phase 3, Phase 4. Now, Phase 1, what do you check? You check almost everything here. You check for pharmacokinetics, you check for pharmacodynamics as well. See, you check for maximum tolerable dose, what is the toxicity, and you can check for pharmacokinetics and dynamics except for efficacy. See, can you do all of this? Can you check for toxicity and all of this in patients? No, you cannot. No, because the patient might get even more sick. So that is why it is done in healthy people. Okay. Now, in Phase 2, we will determine the efficacy. In Phase 3, we will confirm the efficacy. After confirming the efficacy, the drug is approved. The drug is gone for approval. And once it is in the market, we will do Phase 4, that is long-term adverse reactions. So, you will check for long-term adverse reactions. Yes. So, Phase 1 is done in healthy people, rest all are done in patients. Obviously, how will you check for efficacy? In patients only. Can you check for efficacy in healthy people? No. That is why Phase 1 mein efficacy check nahi karta. Did you understand this much? Good. Now, coming in, how many people do we do it? See, in Goodman and Gilman, it is clearly written that Phase 1 is done in a few hundred people. Okay. Phase 2, many hundred people. Phase 3, few thousand people. Phase 4, many thousand people. Now, what kind of trials do you do? In PSM, you must have studied open-ended trials and closed-ended trials. Open-ended trials means the patient knows that he is taking the drug. Closed-ended trial means the patient doesn't know that he is taking the drug. Okay. Now, so phase 1 and phase 4 are open, phase 2 and 3 are closed. You can see here the table is open to this side, this table is open to this side, these two are closed, so you can remember it that way. Phase 1 is also known as human pharmacology and toxicology study, because you are studying about the toxicity and pharmacokinetics and dynamics. That's all. Now, phase 2 is known as therapeutic exploratory trial, because you are exploring the efficacy. Phase 3 is known as therapeutic confirmatory trial. Confirmatory trial. Now, what about phase 4? It is known as post-marketing surveillance. So, that's all about the general pharmacology. As I have told, see, some basics had to be explained in the ANS and general pharmacology. I have done my part. I finished explaining the concepts to you. From now on, everything that is left out as systemic pharmacology, you must have studied and covered all of this in so many subjects. So, we are going to go superficially without going into the concepts here. Okay.